My name is Mary Donnelly. I'm a professor in the School of Law in University College Cork, and I have the pleasure of chairing the session for today. This is the second of our 3 webinars, which is dealing particularly with issues in relation to DNARs or DNA CPRs and advanced care planning. And today we are dedicating our session particularly to digging into some of the practical issues around advanced care planning. Just before we start, I get a chance to introduce our speakers for today. I want to give you just a little bit of technical information, and then want to place this seminar in a context of the other seminars we're doing. So the first thing to say, you're joining us on WebEx. If you want to change your view, go to the top right-hand corner of the video screen, and it'll give you a number of options. You can look at each individual speaker, or you can take a grid view. Individual speaker probably works best when we're dealing with Brendan's piece, because everybody else will have their cameras off. But it may be when we move to the panel discussion that you'll prefer to use your grid view so that you can see all the panelists, because they will all be on screen at that point. If you are having issues with sound or internet connectivity, you can dial in. And I know Jacqueline and Ross are going to put the dial-in details in the chat box. Chat box is open. If you have technical issues, let us know, and we will try to respond to them. We have really good technical support. Obviously, we can't guarantee everyone's broadband, but we will certainly try to help post them to all panelists and not to the host, because otherwise they may not get picked up. You'll see a drop-down menu, so just make sure you use the all panelists element. We will try to respond. We've had some questions already, and we've integrated them into our plans for today and what we're covering for today. But some of you will have questions as we work our way through. Please put those into the chat box. We will try to respond to them as we're moving, at the end, and we will try to make the most of the panelists we have with us to give you the best answers that we can. But sometimes we won't be able to get them all because we are on a tight time frame, as of course are you. If we don't get to them, we will either try to address them next week in our final webinar of this series, and also on a frequently asked questions document, which the National Office is currently working on. We have CPD points. We've had confirmation of that since last week. We've got CPD points from the RCPI and CEU points from the Nursing and Midwifery Board. And in the next couple of days, Jacqueline Marie will be sending out emails to everyone who attended with a note of your certificate of attendance and how you can apply for the relevant CPD points. So this is a series of 3 webinars. Last week, we looked at the policy on DNAR, which was developed specifically in the context of COVID. As many of you will know, we have a national consent policy in place, and we're actually in the process of revising it. But when the COVID-19 outbreak occurred, we felt it was necessary to address this specific issue of COVID, DNAR, and advanced planning, and it was something that simply couldn't wait. So this is a specific policy. It will be integrated into the national consent policy, and some changes will be made as we go forward. And obviously, all of your input is really, really valuable in developing that policy, and the things that you need to be covered. The questions which you have are really important in developing that policy. This is our second of the 2 webinars. We're concentrating on advanced planning, and next week we will be talking about supporting people to make their own decisions, both in terms of advanced planning, but in terms of contemporaneous decisions as well. Couple of other things. If you want a sector-specific seminar, let Jacqueline or Marie know, and they will work to organise that. And then finally, we've had a number of questions around nutrition and hydration, egg feeding, and a whole array of issues around that. We recognise that this is a very significant issue, We're not going to attempt to cover it today, other than in the very specific context of today's discussion, but we are planning a session specifically on nutrition and hydration when we resume the webinar series in the autumn. After that, just to take the opportunity now to introduce you to Brendan O'Shea, and I'm really delighted that Brendan has joined us today. Brendan is a GP and he's the principal in a practice in County Kildare. He's also an assistant adjunct professor in Trinity College in Dublin, and he's a member of the Council of the Irish College of General Practitioners. He has a very strong interest in end-of-life planning, and as part of that, he's on the board of directors of the Irish Hospice Foundation. He's been very active in developing and reviewing the consent policy and on the ministerial working group for advanced healthcare directives. So we're really delighted to have Brendan here to talk us through some of the practical issues in advanced healthcare planning from a GP perspective. So thank you very much, Brendan.
It's a pleasure, but also a cause of anxiety for many of us to plunge into this topic, which has been thrown into very sharp focus by the events of the last 3 to 4 months. So the area that you've asked me to address really relates to advanced care planning, looking at the what, why do we do it, when do we do it, and where and what do we need to do. My Ladybird book of public speaking says to really understand who your audience is, and that's become a lot more difficult in this age of WebEx and Zoom, where we often feel we're speaking into a vacuum. But I understand that we've got a really multidisciplinary audience this afternoon, and people seeing and engaging with people and patients in a variety of different healthcare contexts. So really what I have to say, I hope, is relevant to this audience. So it is a view from general practice and primary care. So my own background in this area of care, I've worked as a GP in County Kildare for over the last 30 years in a multi-doctor practice. It might sound terrible, but a lot of our patients have died. But of course, that's what happens to people, even though we often forget it in the busyness of clinical care. During that time, I've had an input in the local palliative care service at St. Bridget's, which was initially founded by my partner in practice at the time, Dr. Adrian McGoldrick. And down the years, I've been involved in providing out-of-hours cover at the hospice and also weekend cover. So that's meant that I've had some increased opportunities to have conversations with people at end of life. I've also worked as medical director at our local cooperative, and in our cooperative, GPs are frequently stressed and concerned at the breakdowns in communication that happened around transitions around end of life. You're caring for somebody in your office during the week, you take the weekend off, and on Monday you find that an individual who was comfortable and stable has been transferred into the emergency department. And then finally, I've also worked with GP training, and we've carried out a number of pragmatic research projects around end-of-life planning, particularly supported by the Hospice Foundation, and particularly with respect to the use of Think Ahead. So these are the clinical experiences that inform significantly what I've got to share with you today, and which I hope might be helpful. Looking back and overviewing our health system as it is, and certainly after the last 3 bruising months, we are asking ourselves, what are we going to do should the pandemic come back and the next pandemic? We certainly have been challenged, and the challenge has been very focused around end-of-life care, and particularly in relation to nursing homes. Standing back and looking at healthcare systems, we do understand that healthcare systems that have well-developed capacity in primary care generally deliver better outcomes across all spectrum and all areas of care, better outcomes at lower cost. And I believe that this actually holds true also for end-of-life planning. I believe that the evidence does support that end-of-life planning is best when it's done earlier, and it's best when it's done with an individual who is still reasonably autonomous and not too acutely sick, earlier in the disease trajectory of the common conditions that we see, rather than waiting until we're very close to end of life with a stressed individual, often in a very busy care environment, for example, the emergency department. These principles are very much reflected in the chronic care model, and the chronic care model in turn, it's endorsed by the WHO, and our own policies of Sláinte Care and Healthy Ireland very much move us into this space. This is arguably the way our health system should be going. So when you and I find ourselves challenged by this, either as a nurse, as a consultant, as a general practitioner, as a physiotherapist, as a family friend, what are the issues? What problems do we experience? What do we find useful? What actually works in this area of care around end-of-life planning? What can we do differently is important. Do we believe after the last 3 awful months that we're actually well placed to make a difference? These are important questions, but they're not as important as the next question. And the next question is if we got it right, what might good end-of-life planning actually look like? When we have the conversations, and particularly in the context of COVID, where many of us were encountering a large number of people suddenly brought to end of life, so we had a challenge in terms of volume of care as well as complexity of care. I think we found that exceptionally challenging to an extent that our ability to visualize or imagine what good end-of-life planning might look like actually becomes impaired and damaged. When you talk to a bunch of any kind of clinicians, very often around end-of-life care discussions, we immediately put ourselves into the legal or the legislative arena. So for the next couple of slides, I'd like us to speculate maybe a little bit more constructively. If we got it right, what would it look like? GPs and practice nurses have had our vision of our care system completely changed in the last 3 months, but certain things are still carrying true. We're still delivering high volume personal care in the community. People are coming to us in significant numbers, and many of them can be picked out as complex, frail and vulnerable. And if we have the time and the interest, we can become better at identifying earlier the ones who are likely to die in the next 6 months. We particularly know that the population of people in nursing homes, numbering circa 26 or 28,000 people, we know that they will be particularly vulnerable and at risk of dying should there be an increase in the R number and a recurrence of the pandemic. In general practice, we feel we could do a better job if there were some more GPs and a lot more practice nurses, because that would give us more time to have more conversations earlier with people in a way that people need and deserve, and engage their families. Part of our problem collectively, however, is that we and our friends in secondary and tertiary care often seem to be in constructive denial about end-of-life planning. We almost seem to believe it can do later or it's somebody else's responsibility, but then it happens. And we have just had the last 3 months where it happened in large numbers within nursing homes. We need to take steps to prevent that happening again. General practice kind of looks like this slide. I don't know if you can see it, but it's a slide of a big call center with everybody on telephones. And that seems to be how we're delivering over 3/4 of our care and practice at the moment. But we can make this work too, and we can make it work around end-of-life planning, providing we have the focus, the interest and the right tools for people and their social carers. So slide 8 asks us, what might good end-of-life planning look like? On the right of the slide, you'll see the crest of the Royal College of General Practitioners, and on top of that, there's an owl. And we often ask medical students, what do they think the owl represents? And the medical students always kindly say, well, I'm sure it means wisdom. But of course, we feel actually that's not what the owl is about at all. The owl is there because they're good at finding their way around in the dark. They're good at dealing with uncertainty. The motto of the RCGP is Cum Scientia Caritas, with science and kindness. And I think these two values, tolerance of uncertainty and maintaining a kind demeanor and not being taken over by panic and anxiety, are key to helping us in the months ahead. So on slide 9, we can see the signposts on slide 9. We want to shift from this lost, confused state of mind to a better feeling for what's right and what's less helpful for people who are at end of life. So moving on to slide 10. On slide 10, these are some of the bullets that we often beat ourselves up over, that we don't think ahead, and we have reasons for not thinking ahead. We have reasons for not doing end-of-life planning. Irish society is getting significantly better at discussing dying, death and bereavement, but there's a little bit more to go. There's been great work done around this by the HSE, by the Hospice Foundation and by various other agencies, but we still need to make this a standard, acceptable, important and welcomed and valued discussion. We often don't do advanced care planning because of avoidance, particularly with patients that we really like. It's a difficult area to broach. We are very busy, and we have seen that most acutely in the last 3 months. But clinical care is like that. Clinical care is also complex and fragmented. With all of the other issues, we can sometimes assume that this can be left to somebody else. But today, at lunchtime, at 2:27, as it now is, can you swear to yourself that you'll take up the responsibility for this in your nursing home, in your ED, in your hospital ward, in your palliative care unit, in your general practice, that you will make sure that the right things are being done. You mightn't necessarily be doing them yourself, but in your service, that you will be the lead in this in terms of deciding that people will be provided with opportunity of life care. It doesn't require an awful lot of time, it requires a modest amount of time. But with focus and skill, you can deliver the consultations in a way that people deserve, and increasingly in a way that will be required on a legislative basis in terms of providing care in a manner fit for purpose in 2020. We often delay these conversations because of legal uncertainties. And while we should be focused on interpreting what's happening and answering questions and presenting the options, instead we're actually catastrophizing, and we see ourselves in inquiries and on committees answering up for the mortal sins that we've committed and the deficiencies in our care. So let's take ownership of this issue in a positive, holistic way. End-of-life care is not a professional value. We will talk to students and trainees of all disciplines about diabetes. We will talk about HbA1cs, lipid levels and therapeutic exercise coaching, but we never assume that the diabetic patients are ever going to die. In the ICGP, we are moving to ensure that end-of-life planning is reflected in all of our chronic disease protocols around multimorbidity. And this is something we need to do, that it needs to be stitched in right from the very beginning at the onset of any significant life-limiting condition. And we have, as I've referred to, a heightened sense of professional inexperience and unease about this. So cumulatively, we don't know when to initiate the conversations. This leads to procrastination, and then things fall between not stools, but great chasms. On slide 11, why do we need to think ahead? It avoids additional uncertainties. It reduces costs, which is a bad, good reason. But if we make the right decisions, we understand it increases the probability that people will be cared for in their own homes, in the nursing home setting, all of which is significantly less expensive than doing so in a secondary or tertiary care setting. Reducing the uncertainty around end of life almost certainly reduces existential suffering. So, hey, it actually feels good to do this. So if you haven't done much of this in your clinical care, plunge in, okay? And it will be difficult and stressful the first consultations you embark on, but like any other complex task that you've taken on in your professional life, as you begin to do it, you will go up on a learning curve. You will enjoy significant and positive feedback from the individuals and their families because of your interest and your skill in managing these conversations. On slide 12, when should you think ahead? Well, today. Today's a good day, okay? Think ahead for yourself. Have you put yourself in a critical care environment? Have you imagined yourself with a life-limiting illness? Some of you have almost certainly experienced breast cancer and prostate cancer firsthand, but I suspect many of us mightn't have imaginatively put ourselves in that situation. In my practice, and for many years now, when I see an individual and they come in the door, or I'm on the phone to them now, and I can see from my electronic medical record that they've turned 50, I will often say, "Oh, Paddy, you're 52, and I haven't seen you for a year or two. This is something for you." So I increasingly give out think ahead in that context. I certainly use it systematically at 6 to 8 weeks after a new or significant diagnosis. So if somebody is diagnosed with type 2 diabetes, when they're coming back for their second and third visit and their HbA1c has reduced, and they're beginning to feel comfortable with their diagnosis, I'll provide them with think ahead. And I will say to them, we're giving this increasingly to people at the outset of a condition. I think you're in no fear or danger at the moment. In fact, I think you're probably good for another 20 or 30 years. but I know that the next years will become medically more complicated, and I think you might find this helpful. Take it home, have a look at it, show it to John as your better half. There's a lot of information in it, and it's fairly clearly laid out. I don't think you're going to need it immediately, but I do know if you think your way through it, it will make certain decisions later on easier and safer for you, and they'll be well documented. It's encouraging you to think, to talk about your end of life care and how you'd like it to be arranged, and to tell it to the people who are important around you. It should certainly be considered in people who have become complex and frail, and maybe the over 65s or 70s, who usually have complex multimorbidities. They should have that opportunity to have that consultation. And today I feel stronger than ever, and I'm sorry about a feeling, they are to be mistrusted, but in view of our last 3 months, they should absolutely be considered to have these conversations using a tool like this, usually within 6 to 8 weeks following admission to a nursing home, because we know the average survival in a nursing home in Ireland had been 22 to 24 months. So anybody who is that close to end of life should certainly have the conversation. They can have the conversation with a nursing colleague who has an interest and a skill and experience. They can have the conversation with the GP who is visiting. It might be the director of nursing. It might be a physiotherapist who visits the nursing home and actually has a talent for this. It doesn't matter who does it, but the senior clinical decision maker in the nursing home needs to know that these conversations are happening, that they're informed, and that they're documented. And in perhaps a third of cases, the individuals who we are inviting to participate won't be able to participate. But the attempt should be made, and if because of moderate to severe impaired cognitive function, they're not in a position to fully engage, we should engage to the extent we're able to. But again, I'd put it to you that it is surprising that people, even with mild or moderate impaired cognitive function and their families, they can actually engage to a surprising degree if they're given the opportunity. I think it'll be good to work through this. And a second opportunity to gather any thoughts that they might have and to document that. The first times you do it, it may take you 10 or 20 minutes. It may take you 10 or 20 minutes twice. But if you get more comfortable with the discussion, and if you're clinically good, as most of us are, you will tailor and pitch your conversation in a way that will be effective, will work, will be hugely appreciated. And it needs to be done. It needs to be done for everybody who's in a nursing home. It probably is not acceptable to simply tick boxes without reference to the patient. The individual requires to be referred to and engaged in the conversation. So there are many right answers to when is the right time to do end-of-life planning, but there are 2 wrong ones, which is never or later, because later will catch us out. Next slide. So moving on to slide 13, shift the conversation from the acutely unwell pre-arrest ventilated patient, that's where we've been, to several years earlier in the community. The conversations work best for a clinically stable autonomous patient. Next slide 14. So we have some pragmatic studies around Think Ahead. And to lead you into it gently, the initial study we did, we gave Think Ahead to a sample of 100 patients who were attending a general practice setting for routine care. These were aged 40 to 70. They were coming in for blood pressure checks or diabetic checks. We did a telephone look back 2 weeks later. We asked them to look at Think Ahead, take it home, have a chat with your next of kin. We'll ring you in 2 weeks to see how you're getting on with it and to see what you think about it. They looked at us a little bit strangely, but they were given an information sheet in relation to it, and the booklet really explains what it's about. They got a phone call 2 weeks later. These are the responses we got. Next slide. Over 6 out of 10 reported no difficulty in filling in this. This was a booklet about their dying. They did identify some areas that caused difficulty, including I don't understand issues around CPR and ventilation, and they had difficulty completing some of the sections around legal and key information. So their comments were reflected in this version of Think Ahead, which has been improved and beefed up around those issues. Next slide, slide 16. We asked them, should Think Ahead be changed? A staggering over 8 out of 10 said no, it was just perfect the way it was. This reflects the great work that was done with this document around the forum on end of life between 2009 and 2012. It was subjected to an international peer-reviewed review of the peer-reviewed literature, looking at other instruments around the world, and their good ideas were incorporated. It was also the subject of numerous focus groups up and down the length of the country, and indeed a significant level of interdisciplinary committee work. And this is the outcome. And we are very relieved that over 8 out of 10 people who used it in this sample were positive about it. And again, they made some recommendations, and these recommendations are now incorporated. So the current version includes feedback from the users. Should Think Ahead be introduced more widely is on slide 17. And again, 86% of the sample said it should be introduced more widely. On slide 18, which is perhaps the most important slide. On slide 18, the question, has reading Think Ahead caused you to discuss this with your family? So you're the therapist, you are the nurse, you are the doctor, you are the psychologist, you've given Think Ahead. What impact has it had? In our study, we were thrilled that in 83% or 84%, this caused conversations to happen outside of our consultation between the family. That's a very powerful reflection of how effective Think Ahead is. And it's a very strong marker of how effective it is as an end-of-life planning tool. We do understand that it won't be quite as easy to use in the nursing home setting, where there's a higher prevalence of significant impaired cognitive function, but we do believe it does represent a significant part of the solution for a still substantial proportion of individuals, and it is very helpful in putting their family in the picture in a very efficient way outside of your consulting time, which is necessarily very limited. Slide 19, key question. Over 3/4 indicated they did not find Think Ahead upsetting. 26% or 1 in 4 reported some parts of it caused upset. The areas identified, we didn't like When I Die, and we didn't like the care preference section. So again, these sections have been improved. Again, pragmatically, it is better perhaps to experience the upset while the individual is still well and can work through it. It's arguably far more upsetting to experience the upset much closer to end of life. Have the conversations earlier than we're doing. So moving to slide 11, this study demonstrated Think Ahead is very effective at having the work done, often with the family outside of the consultation. Emboldened by this, and relative to the frailer complex patient, we then did a second study using the same methodology. It's detailed on slide 21. It's published in the British Journal of General Practice. We used exactly the same methodology, but this time we used a similar sample size of people who were expected to die in the next 6 months, as identified using the SPICT criteria. So this sample were complex frail people with advanced metastatic prostatic cancer, with advanced motor neuron disease, with breast and lung cancer, with end-stage COPD. And again, advancing to slide 22, we use Think Ahead in conjunction with SPICT. And SPICT is an important take-home for you if you're wondering whether you should do end-of-life planning with this individual. Once you read it once, it'll sharpen your clinical antennae, and it will prompt you, yes, this person, I wouldn't be surprised if they're deceased, and it is important to consider end-of-life planning. Looking at the results from this frailer sample, again, despite their proximity to end of life, 80% or thereabouts indicated they didn't find any part of this to be upsetting. A majority of them felt that this document would be of interest to people generally, and a majority indicated that it would be better to introduce the document more widely. Moving to the next slide, slide 24, some comments from these people very close to end of life. They had to say, end of life planning, and particularly Think Ahead, makes you think positively about things. It puts things into perspective. We found it very helpful. This area is just like a list of jobs I need to sort out, but I never got around to. A lot of people won't go and get it. A GP should bring it up. This opened a door, allowing family to start talks.
Brendan, sorry to interrupt you. You're playing a stormer here, but I'm afraid because we have to get finished within an hour and a little bit. Would you mind?
I think we have the key messages across, and I think if you have a curiosity about the use of Think Ahead and an approach to the consultation, then I think that's a good place to draw a line under this part.
Thank you so much, Brendan. That was absolutely fantastic. And thank you also for handling those difficulties with such aplomb. And I think that core message, which is that message of advanced planning, but also the practical points which you raised are really, really useful. And I'd expect that you will be probably getting some questions coming in on the chat function about that, and hopefully we'll have a chance to get back to it. Could I ask the panelists now to turn on their cameras, if you don't mind, and that is Sean, Fiona and Louise. We're very fortunate with our panelists today, and I think they all bring something quite special, which adds very, very nicely to what Brendan has been talking about. So I'm going to introduce them quite briefly because time is relatively limited. Professor Sean O'Keefe is a consultant pediatrician and honorary professor of medicine in NUIG. He has a very keen interest in ethical issues in respect of older people, and he's been very, very involved in all aspects of the National Consent Policy for many years, and he's currently the joint chair of the National Working Group on the National Consent Policy, but he's been deeply involved in this area for very many years. Fiona Morrissey, Dr. Fiona Morrissey, is an expert in disability studies. She has a PhD on advanced planning. And one of the things which Fiona brings in particular is a much broader perspective on advanced planning and takes advanced planning out of the end of life context only. And that's a really, really valuable thing, I think, for our purposes. Fiona is very involved with the World Health Organization in training in that respect. She's also been very involved with lobbying in respect of the Disability Rights and the Assisted Decision-Making Capacity Act. And she's a member of the Ministerial Working Group on developing codes of practice on advanced healthcare decisions. So we're thrilled to have Fiona with us as well. And then finally, Dr. Louise Campbell is a clinical ethicist. She is also a lecturer in bioethics at NUIG School of Medicine. We don't have many clinical ethicists in Ireland, so it's really wonderful to have Louise with us. And Louise is also a member of the Pandemic Ethics Advisory Group, which has clearly been very influential in developing ethical responses around the COVID-19 crisis. So we're really lucky to have you all. Thank you very much for being here. I'm going to turn first to Sean, then Fiona, and then Louise, if that's okay. And Sean, I said Brendan talked, and if we all listen to Brendan, hopefully we won't have many instances where advanced planning becomes an issue in an acute setting. However, at the moment, we haven't all listened to Brendan, and therefore the issue of advanced planning in an acute setting where a person is acutely unwell, is there anything you can tell us about the most appropriate ways to deal with that? And then issues involving whether or not the person has capacity to be involved themselves, notwithstanding their illness, or whether they don't. So could you talk us a little bit through that issue, please?
Well, certainly, thanks, Mary. Reiterate everything Brendan said. It's so much easier if it's done beforehand and the donkey work is done. In the acute setting, if it hasn't been, you do the best you can in the circumstances to communicate as effectively what the current situation is and the prognosis and what it involves. And you're trying to elicit wishes and preferences, sometimes broadly. And the same principle goes if somebody can't speak for themselves, despite every effort. You involve those close to them to help to know what the person was like and what they would have wanted in those circumstances. But it is suboptimal, as Brendan is saying. But in general, you can do it, but with greater difficulty than should have been the case.
Thanks very much, Sean. That's very helpful. And actually kind of linking to that point, and it's a really practical point, is the issue of transferring between services and DNARs. So again, it links your point with Brendan's work. So we'd say Brendan's hard work has happened. How, if services?
It's one of the issues we deal with in the guidance we published recently and explain it better. What's really important is that the decision, for example, is made in general practice, that it can be communicated effectively in the hospital setting and vice versa, if it's meant to be an ongoing decision. And that means that the person at the second end knows how the decision was made, who made it, what involvement there was in the person, and what the reasons for it were. So it's not simply enough to be sending forms or a simple letter saying this is a DNAR decision. That isn't enough. You need to have some communication about the process of communication so that the receiving person, if you like, kind of confidence that it was an appropriately made decision.
Super, that's excellent, Sean, and I'm sure we'll be getting some questions coming in as we move along. What I might do is move along to Fiona now, and then we can respond to questions as they come in. Fiona, I suppose one of the many things which you bring in this context is this awareness that advanced care planning is not just about end of life. So I suppose one of the issues is to think about, why should a person make an advanced care plan, both in an end of life context, but more generally, why do you think it's an important thing to do?
As early as possible, as people were saying, but it gives people a sense of control over their lives. And you have to remember that most of the advanced healthcare planning cases actually come up in the context of women in road traffic accidents. So it's something we should all be doing, appointing who we want to communicate our wishes if we're unable to communicate healthcare decisions ourselves. And we see cases in the courts at the moment where young women are on artificial nutritional hydration, and decisions are being made, but we have no concept of what their wishes might be in this situation. So it gives people a sense of control over what happens to them. And then in other contexts outside of end of life, like mental health, it helps people recover and gives them that kind of, empowerment that their wishes are being respected. And of course, if you are treated in accordance with your wishes, you have better healthcare outcomes. So it's really important as well for you and your family, that it reduces that decision-making burden and stress on you and your family. That trauma of having your family not knowing what your wishes might be in this situation. So really it's about, empowering the person, allowing them to be listened to, and giving them a sense of choice and respect, and having their voice heard, and giving that sense of autonomy and dignity in relation to their healthcare and their lives in general. And it also increases the sense of trust people have in healthcare professionals as well. We must remember, as healthcare professionals, or healthcare workers should also have advanced care plans. And we saw in a recent survey that 95% of Irish people have planned ahead. So we all need to be doing this. And it's something we all need to consider. But since the COVID crisis, 23% of people are now considering doing that. So it's up to healthcare workers then to try and initiate those conversations and have an engagement with the wishes and preferences of the person. And it's really important as well for the person to feel like they're being listened to. Because I did a piece of research here in Ireland, and the thing people want the most is a sense of being listened to. And if we don't have that engagement with the person about what their wishes and values are, we don't know what they might be. And someone then else will make that decision for them if they're unable to communicate themselves. And that decision may not be in accordance with their wishes. So it's really, really important to be having these conversations with people around us, with people we're treating as healthcare workers, and to have our own advanced healthcare plan as well. And to use it outside of end-of-life contexts. As I said, in a mental health context, it can be really important for the person's recovery and gives them a sense of control over their treatment, future treatment, and maybe prevent relapse and readmission into hospital. So it can be used also in maternity care settings as well. Women's preferences around birthing. Really, really important to be having these conversations, not just around end-of-life decisions. What our values are in relation to our lives, who do we trust to make decisions for us, and what treatment we might like to have.
Thanks, Fiona. I think you finished. Fiona?
Yeah, hello? Sorry, Mary.
Hi, Fiona. Sorry, I missed you for just a small second there. But I think one of the points you're making here is the power of advanced planning in situations which are outside of the end of life. So, for example, as you talk about maternity, mental health situations as well, would you see a role for advanced planning?
Yeah, they're critically important to mental health. And I suppose the advantage in mental health is people often have previous experience of treatment, so they know what works and doesn't work for them. So it gives the person a forum for communication and reflection on what worked for them in the past and what might work for them in the future. And in fact, it's part of the recovery process. So if I'm advanced planning, thinking about what worked in the past for me, it's less likely that I'd have to be readmitted into hospital in the future in a mental health context. So thinking about what treatments worked, didn't work for me in that context. So it's really important for the people to feel like their wishes are being respected and listened to. And it also reduces the need for coercion and non-consensual treatment, because that causes additional trauma for the person and the family if they have to be treated without their consent or under coercion. So we want to avoid that for people, and as healthcare workers, it makes us feel better if we don't have to treat people under coercion, obviously. So the outcomes are better for everybody.
That's brilliant. Thank you. And actually, could you just maybe quickly respond to a question we've just got in here on the chat, which is the difference between advanced healthcare planning and advanced healthcare directives?
Well, advanced healthcare planning is not a legally binding document, whereas an advanced healthcare directive is a legally binding document. But that's not to say that the advanced care plan won't stand up. It's obviously a very strong statement of the person's wishes. And an advanced care plan actually can form a very strong basis for a person to develop a legally enforceable advanced healthcare directive if you wish to do so. In fact, it's probably better for a person to develop an advanced care plan first before they make it a legally binding document. And of course, it's not just a one-off document. It's an ongoing engagement with the person's wishes and preferences, not something that you just do and leave there in a drawer. So we should be engaging in these conversations with people all of the time.
That's really really excellent, and that linkage between planning and directives. It's not that directives appear out of thin air. The planning is an essential part of developing an advanced healthcare directive. That underpinning. What can healthcare workers do? I know Brendan has talked a lot about what healthcare workers can do, but I'm just noticing something there, which is of course advanced healthcare directives as yet until the Assisted Decision Making Capacity Act comes into force. They don't have statutory force, but they are, as you quite correctly say, are likely to be legally binding, but the Act itself hasn't yet come into force. But in terms of what healthcare workers can do, both in terms of sort of building on some of Brendan's points, do you see anything that you would add to that in terms of what healthcare workers can do in engaging with people around advanced planning and supporting them to advance planning?
Well, obviously, it's really important that healthcare workers initiate these conversations, because sometimes otherwise they don't happen. And so it's important that the healthcare worker gives the person the information they need in a form that they understand, gives them time to make these decisions. If necessary, refer them to independent support, so that could be advocacy support, and allow them to talk to trusted people around them. And in some studies in the States, they found that it took 3 sessions of 90 minutes before a person actually developed a legally binding advanced healthcare directive. So this can take time. It may take a few sessions before the person actually comes to the decision that they want to make. So it's important for healthcare workers to initiate that conversation, give the person the support and information they need, and the time they need to do it. That's critical, I think, and I think Brendan alluded to that. So it's that engagement, and don't leave it to someone else to start the conversation. Start the conversation with the person, and in part of an overall context of their wishes and values, not just about end of life, what their wishes and values are in relation to their lives and people around them.
That's super. Very many thanks, Fiona. I know we'll have a couple of questions that we'll be coming back to you shortly. I might turn to Louise briefly. Hi, Louise. Thank you for joining us also. Louise, Fiona there talked about support, both everyone, Brendan, Sean, Fiona have all talked about the need for support, the need for time, the need for engagement. I suppose a challenge in this context is how to avoid leading the patient. So in other words, listening to and responding to, but not leading. How do you see any challenges, or do you see any challenges in that context for healthcare workers working with patients in advanced care planning?
So thank you, Mary. I think historically we've talked in healthcare a lot about best interests, when what's meant by that is the person's best medical interests. But if you really look at that idea, there's really no such thing as purely medical best interests. I think if you have a proper discussion with any person, any patient who has capacity, they'll have a view about, what they'd want if they became seriously ill. what level of impairment they would find acceptable. These are detailed, nuanced conversations. They're not quick conversations, obviously. Whether they'd find permanent loss of mobility tolerable, what trade-offs they're willing to make. But these preferences rest on the person's values, what's really important to him or her in the context of their life, as Fiona mentioned. And the only way you can find out these preferences is to ask. You can't assume on the basis of a medical consideration of what's clinically best for somebody that all of these other factors will just become knowable. And this can be very challenging for healthcare workers. And a patient's preferences may change over time when they receive more information or as their illness progresses. But ultimately, the dichotomy between their best interests medically defined the dichotomy between best interests generally and preferences is actually a false one. What's best for the patient incorporates her medical best interests as well as her preferences based on this informed understanding of her situation and on shared decision making with the healthcare provider. So if we put into practice the principles of shared decision making, trying to reach a shared understanding between healthcare worker and patient in relation to what the illness means, we've a much better chance of moving beyond this idea of directing the patient or trying to nudge her in the direction of what is medically deemed to be her best interest, where her preferences might conflict with that.
Are there any tools that can be used, Louise, in terms of helping people to, care workers to, in a sense, recognize this? Is there any, from an ethical perspective, are there tools, are there ways in which people can, in a sense, check their own, I suppose, biases or prejudices, what in this context?
I think this, just to reinforce, this whole conversation is value laden. You know, these decisions rest on 2 feet, the medical facts and the values, not only of the patient, but of the doctors or the healthcare worker as well. And I think being able to evaluate or to analyze one's own values and to make those clear is as important as actually being able to help the patient to elicit his or her values, what's important to her in the context of the way her life has gone. I think the more skillful the healthcare worker is in communicating, the more likely it is that the person will trust the healthcare worker with these important pieces of information and will listen to their recommendations. And again, that breaks down the dichotomy between best interests, so to speak, and wishes and preferences. I think communication requires all the skills that the literature points to: empathy, sensitivity, humility, patience, active listening, an ability to get at the patient's perspective, an ability to broach the subject, say, of serious illness in the context of starting to talk about advanced care planning or advanced healthcare directives. And many healthcare workers possess these attributes, but they don't necessarily have the targeted, focused training to identify the opportunities to actually have what are sometimes very challenging conversations and to arrive at a shared decision with a patient in relation to end-of-life preferences can be very, very difficult and time-consuming, as Fiona said, but very, very rewarding for both parties, actually, as Brendan said earlier. And it should be acknowledged that there are lots of challenges, but I think with skill, resources, and time, these can be overcome. And tools such as Think Ahead provides a really valuable resource or a tool to enable healthcare providers to start having these conversations and to enable patients to start thinking about them.
Sorry, Louise, thank you. It was really helpful. My mic was refusing to unmute. It was enjoying it so much, it was refusing to unmute. Thank you. That was a really, really helpful answer. And I think it links all of the points which have been made earlier. The final one, which is in the context of end-of-life care, or I suppose most specific to that. And sometimes people worry that advanced planning or advanced care planning or advanced healthcare directives links in some way to, I suppose, euthanasia or a feeling of devaluing of life. And what would your thoughts be around that in terms of ethical distinctions in this area? And what do you think about the way in which are the ethical implications from, we'd say, a euthanasia type perspective of advanced planning on the one hand and advanced healthcare directives on the other?
So I suppose, Mary, advanced care planning, I would see as a process whose outcome is a set of documented preferences or an advanced healthcare directive. Just to contextualize that, and if I have time, I'll talk about the two of them separately. But often what they have in common is they may state a refusal of treatment in the knowledge that in the explicit knowledge that this will lead to the person's death. And I think it has to be made really clear that here, the death which occurs as a result of refusal of treatment, i.e. Withholding of treatment, or also of withdrawing treatment, it's permitted by law and by most professional guidance in most jurisdictions. The cause of the patient's death is the underlying disease or complication. By contrast, euthanasia is a deliberate action taken with the intention of ending somebody's life in order to end their suffering, in most cases on their request or with their request. The healthcare worker's action and not the disease process itself is the cause of the patient's death in euthanasia, unlike in situations where treatment is withheld. So a healthcare worker who withholds life-sustaining treatment at the patient's request, or because further treatment is deemed to be burdensome or unable to meet its physiological goals, actually allows death to occur without medical intervention. So death is occurring as a result of the disease process. But if a healthcare worker administers a lethal substance to end the patient's life, that person is responsible for the patient's death. So these are very different scenarios. Does that cover the difference between advanced healthcare plans or advanced care planning?
I think beautifully, Louise. Thank you very much for that. Thank you very much, Louise, and thank you to all the panel. A whole array of questions have come in, and Brendan has been playing a complete stormer here and responding to lots of them in the chat box, for which we are deeply grateful, Brendan. So what I'm going to do is zip through some of these questions which have come in, ones which maybe Brendan has not yet responded to, or to give people a chance to talk a little bit further around this. I know one of the early questions was the idea of should the and I suspect Brenda will have an answer on this one. Should the Think Ahead form be sent to everybody in the country? Is this something that should be?
Well, in general practice,
exactly.
We do see our process of care. We see our electronic medical records. We would be in favour, some of us, that once everybody turns 70 on their 70th birthday, that there should be an end-of-life planning consultation at their 70th birthday. There's a similar scheme that's been running in Australia. It's not so much focused on end-of-life planning, but it's a consultation with either a GP or practice nurse, and it's an evaluation of unmet need. And end-of-life planning is reflected in that. And that's been working very well for 2 to 3 years. It will be relatively very inexpensive. You can tick the parameters around it so that any general practitioner can press the button on their record system and see what percentage of over 70s have had the consultation. And we can also put standards around the consultation, that the consultation would include, for example, evidence of having handed over a copy of Think Ahead and any other follow-up consultation. Now, everything in general practice is less expensive. This is the least expensive way to actually do this, but we understand that the value from this would be very significant, and it would put us all in a better position, and most importantly, put the individual in a better position, that they're stimulated to think at a time while they're still well enough to think.
That's brilliant. Thank you very much, Brendan. By the way, just to let people know, because we had a little bit of difficulty earlier with the slides, etc., notwithstanding how brilliantly Brendan handled that, we go over for about 5 to 7 minutes, so we will still have a chance for a few questions, but we can't do any more because you obviously all have lives to get back to. Sean, can I ask you one here, because I think this is close to your heart, which is it legal for the next of kin to make a DNAR decision for cognitively impaired patients?
I think the premise of the question is wrong to an extent, in that if the patient, if nobody else has decision-making authority, then they can't make the decision. And it's probably unfair on people, that burden on them, that they're making a life or death decision, when, as Louise said, the disease is actually the one making the decision as to whether somebody is going to live or die ultimately. I think it's fair to say the role of those close to the person is to be aware of the person's wishes and preferences and to convey those. So it's a process of communication, but they're not making the decision, they're not signing a death warrant, as people are sometimes regarded. So involvement, but to make it clear that they're not carrying the burden of that decision.
Sean, that's excellent. And while I have you, although I know many of the panelists could answer this, but while I have you, time limits. Are there time limits? How long is a DNAR live for? advanced, but we'll stick with DNARs as that's the question.
Yeah, it's actually dealt with in the guidance that we published recently, and that's available. And as to say, sometimes a decision is made in the context of an acute illness and somebody being very unwell, and they improve, at which stage you need to revisit any decisions you made during it based on that illness. A lot of times, though, it's on the basis of a chronic illness. It may be on the basis of advancing cancer or advancing end organ disease, at which stage the condition isn't going to change. And unless the person themselves indicates that they want to revisit the issue, there's no reason for a time limit specifically. So it depends on the clinical circumstances.
Thanks, John. Well, I have you still, because again, I think it's probably a kind of a generic kind of question, which is if you have a hospital developing a policy on this, is this something which can be done at a hospital level? And actually our other contributors may want to come in on this one too. Or is this something which should be done at a national level? So planning around this, and I guess that issue of consistency, which becomes very important. If you don't mind taking me first, Sean, and then I'll see does anybody else want to.
I think we could all see the advantage of a consistent approach. I think ahead is really excellent and fully endorsed with Brendan. Different places have different approaches and different forms and different settings. And the HSE certainly can't mandate a particular way of doing it. We can encourage and endorse them. What we don't want to see is every individual hospital going off and reinventing the wheel and coming up with a fresh new policy. Is simply pointless. So it's taking the national policy as the overview, and what needs to be done locally particularly is finding out how you're going to implement it based on your setting and your particular requirements. So there may be different ways of documenting, for example, but there's more than one way to skin a
cat. Thanks a million, Sean. Anyone else want to come in on that one? Okay, you get to jump in very quickly or not. So actually, I'm going to throw this one to Fiona, if that's okay, Fiona. And then I suspect others may want to come in on it as well. I think it's probably a really live issue for many people, which is where there's a dispute with relatives. So you're trying to do end of life planning or advanced planning, and relatives don't want you to engage in this process. Maybe in a residential care setting or otherwise. Maybe if you, Fiona, could talk about it a little, and then we might try some of the others as well, because I think that issue of conflict is, imagine, on the ground, a very real for people.
It's a real issue, that comes about all the time. So I suppose it's important to keep family on board, but also to keep in mind that ultimately it's the person's wishes that should be at the centre of these decisions. This is something that comes up all the time, and I suppose the conflict between family members and the person. But as a healthcare worker, I suppose the focus should always be on the person. But I suppose it's important also to try and keep the family on board and try to explain the process to them. So, you don't create that conflictual situation if possible. But ultimately, I suppose always the person's preferences should be kept at the centre of all these decisions. And in fact, if you engage in advanced healthcare planning, the research shows that you're less likely to have this conflict come about, particularly when a person is in an end-of-life situation. So actually, by engaging in this, you're probably diffusing that conflict in a sense, rather than actually, escalating it. But it's about also, talking to people around the person, but ensuring that the person's wishes are what are kept at the centre of the situation. Because what you want and what your family might want might be two very different things. So we need to be always conscious of that when we're talking to people.
Brendan, do you want to add anything to that? I saw you nodding there. And Louise, I think also. And you need to unmute, Brendan.
I got the unmute thing this time. I think this has been a very positive conversation. I think there's actually a real curiosity. There's a desire to make things better. I think we are gathering the wherewithal to provide better care. I think the COVID experience, while it has been very difficult, it has really moved us on. But I think there's more to do, and I think we will move the situation on. I think we will provide better care in this regard. I think I'll stop because I don't have anything else pressing to say, but I think the comments on chat, as always, have thrown up all sorts of interesting possibilities and comments. I think the best comment on chat this afternoon is from Caroline Heffernan, who clearly identifies herself as somebody who's a complex medical situation, and her comment is that the professional having this conversation needs to be comfortable and have thought about end of life themselves so that they don't have that fear in their eyes during the conversation. I think that's just really important. And the only way we can actually put ourselves in that situation is with our imagination, with our clinical experience, using the best tools that we have, using a bit of peer support and reflective care. This will get better.
Fantastic, Brendan. I think that is quite a wonderful place to end. Louise, you had just one. Did I see your hand go up, Louise?
Mary, I just wanted to add into what Fiona was saying there in relation to the potential conflict between families and healthcare workers. Families, I think it's really important to understand families' motivations and where they're coming from as well. I completely agree with Fiona. I think they may be grieving, or they may be guilty, or they may be grieving in anticipation, and they may be simply trying to protect a family member with whom they've never had this difficult discussion, all on the basis of wanting to protect them. So trying to see where they're coming from is really, really important. And I think communication training that involves role play can be very, very helpful in working all of this through for healthcare professionals and giving them the confidence and taking away the fear out of their eyes that the texter was mentioning there.
That's brilliant, and that is such a lovely description of the fear in the eyes, and as you say, Brendan, the need to engage for professionals themselves to engage. Going to zip through a few last questions in 1 minute flat. Sean's already answered the one about enduring power of attorney. So under current law, and indeed under the proposed, when the Assisted Decision Making Capacity Act comes into force, powers of attorney will not have the power to make DNAR decisions. The only kind of power that can be given in that context is to a designated healthcare representative. We have a question about when is the Assisted Decision Making Capacity Act going to commence. We are now pretty clear it's mid, or not the beginning of, but into 2022. And I see a question here: of advanced care plan is in place for the elderly by nurses in a residential care facility. Do I still need to do advanced healthcare directives? Sean, I see your mic is off. Grab that one fast.
Yeah, an advanced healthcare directive is different. They're complementary. It's important to say that advanced healthcare directive is drawn by the person themselves, and there is no need for medical input whatsoever once you comply with the law as it will be and the formalities. So that somebody can write a healthcare directive in crayon on the back of a cornflake packet, and it is a legally binding document and legally binding refusal of treatment. And there's no need for doctors to approve or ratify or get involved in any way. So it's a very powerful instrument, and it is distinct from advanced healthcare planning. I agree with Fiona. A lot of times having the planning first is a good idea in terms of getting the directive that you want, but there's no obligation to engage in it. Very powerful, and the person himself has to do it.
Thank you very much, John. I would like to thank all of our panelists, and I suppose particularly Brendan, who dealt both with technical difficulties with great calmness and also delivered a really smashing paper. I think there's a great deal of agreement here, which is about the importance of conversations, about the importance of knowing oneself as a healthcare professional and a healthcare worker, and also very strong endorsement of the Keep Ahead model. So I'd like to thank very much again all of our participants. I'd like to thank all of you for attending. We will be back here next week, and Fiona will be leading on supporting people, both in people who may have challenges, supporting people both in terms of advanced care planning, but also in terms of making advanced care planning in the long in advance, but also people who have to advance care plan in the immediate and challenging situations. There's still an awful lot that can be done for people in that situation. So we want to talk some more about that. So thank you all very much indeed. And hopefully if you have any further questions, we will be able to deal with them next